Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
James, we're going to talk about the Relativity 020 study today. This is Nivo Rela after PD-1 exposure in melanoma. And then a subsequent letter to the editor that came out in NEJM related to this sort of landscape. But before we do, because we have recorded already one post-ESMO 2024, you asked me last time, what was the most memorable? What about for you? This was a pretty big ESMO for you. First of all, what's a blue arsed fly? A. B, what was your most memorable memories, plural? Assume you have more than one.
Yeah, I don't know where the term blue arse fly comes from, but it just means something that's like really running around like crazy and probably not achieving much. I was probably referring to myself. That's A. B, I guess socially, we often have a sort of football tournament at big meetings, which is between, different countries. And it's not very serious. Anyone can really turn up with a team, male and female. I'm going to stress now as well. So the Dutch team, for example, I think had 3 female players, and it was quite a nice setup in Barcelona. So there were places for people to watch. So lots of people have brought, their friends and stuff, and they were kind of waving flags. The actually Turkish flag was particularly memorable. Anyway, so that was fun, but the most fun bit was our friend Tony Shueri. Hi Tony, if you ever listen to this, who's Dana-Farber, had a football team which was US/Lebanese, and I don't know how many goals we beat them by the quarterfinal, but we stopped counting after 5 or 6. So that was fun. But that's all fun. Although I'm still carrying the injuries because I'm too old to be playing football. And then
your team had some really good merch. I mean, you were sporting some great jerseys, I have to say.
Yeah, so obviously sponsored by our podcast, and then Lynn Schuchter, I think, was there, and she took a picture of us, in the shirts and stuff like that. So that was great. It was nice to meet her as well. So it was fun. It's like a fun social occasion with some football thrown in there as well, I think.
With the clarification that our podcast is self-funded, so that was tongue-in-cheek what you just said there. This is an entirely self-funded effort.
Okay, so sponsored by you and I.
Yes.
It's probably the most accurate thing to say. And then kind of, I suppose, professionally, the nicest thing, you were at this session as well, and it was the melanoma mini-orals, I think, on Sunday afternoon, and there were a lot of talks, right? There were maybe 10, I think, and each one was meant to be 5 minutes long with a discussion for each one. And inevitably, or almost inevitably, I think people are running over a little bit. And I think if you don't have many talks, it doesn't matter. But if you've got that many talks and each one overruns by 2-3 minutes, then you've got a problem. And so by the time, as you know, we got to the end of the session, it was 20 minutes over. Luckily, there wasn't a session following us, because otherwise we'd have been thrown out and Bart Naines wouldn't have been able to do his discussion anyway. So we finished the session. It's a good session overall, I think, although maybe too many different abstracts, I think, but a separate issue.
No question and answer, right? No time for question and answer,
Yeah. So I think it would have been better for fewer and more time for some Q&A as well. And I think most people share that sentiment I've spoken to about this. Any case, so by the time it finishes, and I was with Bart and Jessica Hassel, we were sort of jointly chairing the whole session, basically. So we've been up on stage for whatever, the best part of 2 hours probably. I was late for my next meeting by 20 minutes. So I'm kind of rushing to get down from the stage. And, a few people come up and talk to me. And in front of the queue was this guy who I didn't recognise. And, I didn't know if it was an oncologist, honestly, or maybe someone, a patient or advocacy or someone from pharma or something like that. Anyway, and I said, I'm really sorry, I've got to rush off. I'm really late for the next meeting. And he said, Dr. Larkin, If you've got a minute, my name's Rubin from NEJM. Congratulations, and shook my hand. And that was just a beautiful moment because he'd stayed for the whole session. There's any number of sessions he could have gone to.
Yeah.
At ESMO, but stayed for the whole session, and that was just great. And I let Jed Bolchuk know that as well, because I think that was a lovely moment.
Yeah.
I don't think that's going to happen again.
When you tell that story, you need to say this Jeff Bezos looking, billionaire looking guy. Just sort of give it a little more.
Okay, so I need to improve on the story, but That's
I don't think you have to be purely descriptive like this, 180-pound man. But I think you can say this sort of, well-groomed Jeff Bezos looking gentleman came up to me. He's sort of Jeff Bezos looking, kind of, with glasses.
If you say so. I'm not really sure I know what Jeff Bezos looks like, but yeah. That's
also really nice that of all the articles that came out from ESMO for NEJM, this one in particular, the one that you presented, I don't even know if you said what you presented, but this one that you presented got an audio editorial from Eric Rubin. And that's pretty cool that, he spent a few minutes sort of explaining what this means in the field of oncology, and then also just what it means to be curing patients and how those survival curves start to look different.
Yeah, that's great. And I guess we'll talk about that another time, hopefully with Jed Bolchuk, because I think we're both keen to get Jed's insights and perspective on what's been a long story.
Yeah.
So,
By the way, as I was asking about ESMO, I should have asked you a different way. Peak, pit, and bud. You obviously had a couple of peak moments there. It sounds like it was, great fun, football and busy and all this, and meeting Eric Rubin. Was there a pit of ESMO?
No, but I never like kind of running around from meeting to meeting. Honestly, it just feels inevitably you miss things and then you're late for things. I kind of hate that. And if you see what I mean, and then you're running around all these halls trying to find places, and it's just a little bit frantic. And I think it's an occupational hazard, so I can't really give a specific answer. But there was one thing I actually missed, in fact, because a meeting I was meant to go to, because I was kind of being stuck with AV type problems. That's not. I mean, this isn't a big deal, but it's a shame, especially at the last minute before a talk.
I think these meetings are so much fun. I love going to them in person, but honestly, the ratchet sleep that you get, it is like, I'm not even sure if I made up for it this weekend, but it really, really is just, seems like it's sort of burning the candle at both ends. And then these ratchet nights of sleep, early mornings, and then just it starts again and it starts again. And God forbid if you're jet lagged, which fortunately I right-sided up the first day there, but, then you're just really probably, and the older we get, the harder it is to sort of recover from stuff like that. It's not that easy. So
yeah, you'll be fine for a long time yet. But
good, glad to hear. The other thing I like to think of is peak, pit, bud. So then, was there something you came back from ESMO and were looking forward to?
Yeah, not much. Again, I maybe need to be a little bit careful about this, but we had a nice meeting of the ESMO faculty for investigative immunotherapy, which was face to face, and so it was nice to sit down with people in a room and get some nice ideas, I hope, for moving forward. Some of the things we can do, and it's a busy space actually, and you've got lots of things around the world, people trying to do things, but to try and crystallize a few ideas for what's important, especially from a patient perspective, what other people aren't doing already, and also what's, I hope, deliverable. And again, some of this comes back to the kinds of things that, industry may or may not be interested in. Is there scope for getting involved in regulatory discussions or potentially even applying pressure on regulators? I think for patients, these are some of the important issues. And I think for us as clinicians and academics and investigators, honestly, I would say that only part of it is doing the trials. Because, if you just get back to NEJM, I don't know how many trials were reported out of ESMO, probably half a dozen actually. And then the question in my mind is going to be, okay, so the patients can see this, it's all out there, it's fantastic work across the board, but then from that to actually patients getting the treatment,
oh yeah,
I think that maybe this is a little bit preachy, but I think we have to be engaged in that. And you could pick out neoadjuvant if you wanted to, ex-US and melanoma. That's something that fits the bill there. It's not just about generating the data, but there's work to do to actually get access for patients. No, go on.
Is there a cooperative group mechanism in the UK, or is EORTC your main sort of cooperative group?
EORTC is the short answer to that. And they've done loads of trials over the years. They're still active. But again, with the collaborative or cooperative groups, I mean, ultimately going across different countries creates an administrative burden, obviously.
Oh.
And sometimes, you need to do that depending on the trial, but it does create delays. And I think, again, if you're thinking about trials, it sort of comes back to the question, is this a trial where we can do it in a sensible amount of time without having to do that? Or does it really need European collaboration, let's say, or global sometimes, if it's something really rare?
The reason I was thinking about that is because, as you say, it's important to think of a patient's point of view, a practitioner's sort of gap in what they need to know. And then there's pharma and regulatory. But, part of why the cooperative groups in the US have been, I don't want to say that they're wildly successful, but while the reason that there have been in the last maybe decade or so, some ECOG and SWOG trials that you recognize is because it fills that gap between the patient sitting in front of you, the knowledge that you have, and what you have approved. DreamSeq, Mike Atkins' DreamSeq study was a study that we needed to have done. We needed to know if sequence mattered. And you were never going to find that your industry partners were incentivized to ask this question. But academically and just as providers, you were incentivized to know. I need to know if it matters which way I start, which foot I start on. And then it was important for the patient in front of you. So it turned out that trial was hugely important to do. Did it lead to a label change? No. But did it change our practice? It absolutely did. And so the cooperative groups often fill that space of doing trials. Same with S1801. I mean, you could have argued we already kind of had an instinct that giving therapy before, giving it all after surgery was better, but we didn't have a prove it study yet. And so we just took the time to sort of fill in that knowledge gap. Again, one that pharma was not necessarily incentivized to fill. So I just asked that question to know if, in the UK, if you felt like you had a question worth answering, didn't necessarily have the pharma partner in the sense that they would fully sponsor it to the dollar. Do you have a mechanism, or does this really all dump into EORTC and then it has to be multinational and whatever? But
yeah, we do have trials groups in the UK, and over the years we've done quite a lot of trials. There's a VAST-M adjuvant bevacizumab study, for example. Pippa Corey and Mark Middleton. We did a kit study of nilotinib, which is actually, I don't know if I told you this story or not, but it's one of the first things I started working on.
Oh yeah, you did say that.
With Richard Murray, and Novartis provided the drug. Actually, this was in 2008, and given the rarity of KIT mutant melanoma, single-arm trial, it took us years to even recruit it, and we only published the paper last year. So just to pick up something though about EORTC, the other problem we have in Europe is fragmented reimbursement and differences of access to drugs. So, if you just take the EMA label for Nivo Rela, let's just pick that out, right?
Yeah.
So we've actually got a difference between, let's say, the UK, where it's reimbursed without PD-L1 restriction, and then a lot of mainland Europe, where there is an EMA PD-L1 based restriction on the label, and then you've got the reimbursement trouble after that. So from last time I heard, certainly in the German-speaking world, which is the dominant, payer, probably ex-US, certainly in Europe, it's not reimbursed. So then you have another level of complexity in designing trials that you might not have access to drugs as standard of care or to build on or something. So it's not, kudos to the people that do it. This is not, a minor undertaking.
It's not for faint of heart, and we have burned 15 minutes just talking this kind of stuff. Good. This will be longer than the actual episode itself. Fine. Into Relativity 020 we go. You had some good memory on this trial about sort of the lifespan, if you will, meaning the origin story was quite a long time ago and it's only getting published now, a year ago. So there's quite a long lifespan of this 020. Serves an important, probably benchmark for us. And maybe you can tell everybody about this study in PD-1 refractory melanoma.
Yeah, sure. So let's do the citation first. Paolo Asciato and colleagues, and we were involved with this study. Paolo's lead author, Jean-Jacques Grobe, is the senior author, JCO 2023, and I think came out online February 23. So 18 months ago. We were involved in this trial, and it was recruiting for a really, really long time, and there were different cohorts and things like that. And it felt like sometimes they were open, sometimes they weren't. But, maybe rather than dwelling on that too much, just to say, I think the data cutoff was February 21 or thereabouts, so a couple of years before the manuscript was published. And the number of patients, 518 patients in the trial, so two different cohorts receiving nivolumab and relatlimab. And these are basically people who had prior treatment with anti-PD-1. So the question here is really, for me anyway, what's the safety and what's the efficacy of Nivo Rela in this group of patients, which of course we've got lots of patients like this in the clinic. Maybe a quick word on the different cohorts. So the definitions for the cohorts is progression during or within 3 months of anti-PD-1 or anti-PD-L1 containing regimens. Those are the two cohorts. Safety was the primary endpoint, to be clear. Objective response rate was a co-primary endpoint, and there was blinded independent central review for PFS. So I guess that's the background. I think other than that, the inclusion criteria, and again, I speak from, putting patients into the study in clinic, I think were relatively standard in terms of fitness and brain mets and everything else. But I'll just maybe quickly pause for breath.
Yeah, is it possible this particular paper is describing two cohorts? It's like you said, progression during or within 3 months of one anti-PD-1 containing regimen, or two. There goes that thumbs up again. Or two anti-PD-1 containing regimens. So it's a one or more than one PD-1 containing. That's what they report here, maybe D1 and D2, or is the during and within 3 months of is the D1, D2?
I think it's during or within 3 months of. But if you look at, I'm just looking at table 1 now. If we just pick up prior systemic therapy, I mean, basically that's everybody. Everyone's had, it says immunotherapy. A decent number had anti-CTLA-4, but not all. So 40% in the D1, 60% basically in the D2. And then for prior anti-PD-1, anti-PD-L1, it's basically everybody. And just to give an idea of the level of pre-treatment, shall we say, median prior systemic therapies is 2 in D1 and 3 in D2, but with a range of up to 6 or 10. And so this is pretty heavily pre-treated cohort patients. And I guess we could have a discussion about the definitions of resistance and refractoriness, but I think at the end of the day, this is a fairly truly refractory group of patients, is all I would say. So maybe just go on.
Anything about BRAF status that jumps out at you here? It's just a little bit lower than positive, right?
Yeah, a little low. I think I'm just looking for it here as well now. But if you look at, so 20% in D1, almost 40% D2, so almost 40% feels about right to me. And then the number of BRAF targeted therapy was 16 versus 23%. So then there'd be quite a few patients in D2 who probably hadn't had BRAF targeted therapy, if that makes sense. So that would have been, which I think is reasonable. I mean, that's a whole separate discussion about can you be putting, but an important one. But just briefly, I think this whole idea that if you've got BRAF mutant melanoma, you need to have had BRAF targeted therapy, say in the metastatic setting, to be eligible for a clinical trial. I actually, I don't think that's right. I think that personally, and it's an issue for IRBs and ethics committees, it is reasonable to say you failed checkpoint inhibitor therapy. You have the option to go into a trial of something investigational with the idea that if it doesn't work or people aren't eligible, you can then have BRAF targeted therapy as a salvage if you need to later on.
Could you use the DreamSeq study as your example, that the patients who got BRAF second had nearly just as good a response to BRAF targeted therapy, objective response rate, as those who took it first? But we do know, DreamSeq showed it, we know from data from Tony Rebus's lab and others, that when you take immunotherapy after targeted therapy, so to your point, designing a trial that says exhaust your standard of care options, that's the ethical thing to do before taking something experimental. The problem there is the exposure to that targeted therapy may actually give you cross resistance to your immunotherapy that you're starting to study. Whereas if you had just held that targeted therapy for third or fourth line, at least according to some data from DreamSeq, you don't seem to diminish the response rate to that targeted therapy. But using your targeted therapy could diminish the subsequent.
Yeah, I mean, and I've thought that for a long time as well. And I think, not just DreamSeq, but if you look at multiple data sources, if you've got someone and you treat them with targeted therapy, it probably doesn't matter, quote unquote, which line they're in, okay? If they haven't had targeted therapy before, what matters is going to be tumor bulk, LDH, performance status, frankly, all the old school things. Anyway, so I was going to kind of then just basically cut to the chase to say that the safety appeared manageable and tolerable. We're talking about grade 3-4 treatment-related AEs around sort of 13 to 15%. One case of grade 3 myocarditis, no treatment related deaths. And I think, again, from the paper, without dwelling on it too much, and I guess to some extent the experience of treating patients in the trial, that sort of feels about right. But actually, I think the headline is the response rate here, which was unfortunately only about 12%, with tight enough confidence intervals, pretty similar, a bit lower in 12%, that's in D1, and 9% in D2. So some efficacy there, but honestly, I guess not as much as any of us had hoped. And then some analysis to see if there was any enrichment for response using LAG3 and PD-L1 expression. And without going into too much detail on that, it looked like there was a little bit of enrichment if you sort of drew various lines about, thresholds. But were either of those a useful test? No, in a word. So you were still seeing some efficacy in people who were scoring low on those indices. So good effort on that, but I think clinically usable, not for me anyway.
Can I say some controversial statements?
Absolutely not. But yeah, Karen.
Well, look, it's an impressive study. If I look at D1, so I'm looking at table 3, 351 patients. So an impressive number of patients. Here I see a decent number, 84, that are mucosal or acral. Look at those response rates. This is PD-1 exposed mucosal or acral. And now with LAG3, you're getting something there. You're getting, something like 17%, 14% objective response rate. I mean, correct me if I'm really messing that up. And actually that 95% confidence interval for both of those subsets goes long. I mean, it goes, the top end of that goes pretty long. Look at LDH 2x, upper limit of normal. Table 3, hardly a response. I mean, this is something we've sort of said, I'm paying a lot more attention now in my clinic. Just an out-of-pocket at-hand biomarker for, it doesn't mean you wouldn't give this. It just tells you boy, this is going to be harder for that person maybe to get a response. And maybe it's even, as we've talked about, maybe it's even a strategy to try to do something to normalize that LDH, while you're giving this LAG-3 Nivo or, preceding it, but doesn't seem like we're getting a lot of responses in that group of patients. Although fair, there's not a lot of them. There's also not a lot who are just plain above the upper limit of normal, which is surprising when I think of this PD-1 refractory cohort. So kind of makes me wonder if this is like a nicer cohort than we would have seen or not. I don't know. You still have a fair number of M1Cs, but okay. What else? Anything else you're seeing in this study?
No, not really. I think it's a really good number of patients here. I'm pretty confident about the level of efficacy. Some of the subgroups are quite interesting, but then as to whether anyone's ever going to really go after them, prospectively, I don't know the answer to that, honestly.
So then on the heels of this, there was this letter to the editor of NEJM talking about efficacy of CTLA-4 based therapies, either as a single agent or in combination after Nivo Rela. So of course, Relativity 020 is Nivo Rela after PD-1 exposure, but this letter to the editor by several of our colleagues is more about CTLA-4 and single agent combo after PD-1 exposure. So, how do you, first of all, I guess, what's your take on this letter? We went and actually looked at that supplementary appendix that they're referencing. They described 36 patients who had disease progression while receiving Nivo Rela and went on to receive anti-CTLA-4 either alone or in combination. 19 alone, 17 in combination. And we went through and looked at what those combinations were, and they're really kind of all over the place. And the takeaway from this very brief letter that has maybe more authors than word count of the letter itself, just maybe, is that the response rate is about 11% to CTLA-4 based therapy. But how do you put your arms around this data, or do you just sort of put it aside? Because we do actually have randomized prospective data in this space. It's the SWOG-S 1616 study about PD-1 experienced patients. It's not about LAG-3 experience and then going on to get CTLA-4, but it's PD-1. And we have a couple of retrospective series. They all give you this rough same answer. So what do you make of this?
Yeah, so let's just get the reference. Alex Menzies and Ines Perez de Silva, the lead of I don't know how many, maybe 15 authors. And this is NEJM April 22. And like you say, 36 patients had Nivo Rela and then got either treated with Ipi-Mono or Ipi-Nivo. And then, it's a letter, so we don't have loads of detail there. But the kind of bottom line you said already, that the response rate was around about 11%. I think that's right. And then the final paragraph is that these early data suggesting unlikely to respond to CTLA targeted therapy. So I kind of disagree with that, actually, that final paragraph. But it is interesting to look at the supplement where the patient characteristics are listed out. So elevated LGH 58%, normal 42%. So that's a high number of elevated LDH, I think, for most data sets. 53%, over half, had anti-CTLA-4 monotherapy. And I think now, with the benefit of hindsight, we might not say that was the standard of care. It would probably be Ipi-Nivo, and that was the other 47%. But in a way, the most interesting thing is the sort of footnote 2, which is 11 patients that had Ipi-3 with Nivo 1, 3 had an investigational anti-CTLA-4, 25 milligrams MK1308. So we don't really know, I don't know anyway, what the optimum dose of that drug is. 2 had Ipi 1 milligram per kilogram with Nivo 3, and 1 had Ipi 1 with Pembro 200. So to say the very least, I think that's quite heterogeneous. It's a pretty small group of patients. My gut feeling is that the efficacy in general for Ipi-Nivo in this patient population is probably higher than that. And I think, as you've alluded to already, other kind of larger data sets suggest that. So I think the message, the bottom line here, I'm not sure I entirely agree with. And I have to say, other things being equal, I'm still trying to reach for, standard dose Ipi/Nivo, if we want to call it that, classical, OG, as you like to say, in this patient population outside the context of trials, obviously.
Yeah. Fair point. I mean, this, it brings up the bigger question that if you were using both Nivo Rela and Nivo Ipi, do you have a sequence in mind? 020 tells you Nivo Rela second or third line, is low response rate ish. But then this letter suggests that CTLA-4 in combination is low response rate. But then SWOG 1616 tells you, the response rate's probably right about a third of patients with CTLA-4 in combination are getting a response with a PFS, improvement. Anyway, I think it's tricky. I think we don't know the right sequence of this, of this kind of Rela, Nivo, Ipi sequence, so Rela-seq, if you will. Maybe that speaks to needing to do a cooperative group trial. The problem is that it's huge. So we have something proposed in SWOG that's not going to quite tell us about sequence, but it's going to give us some more insight here. But what else do you think? Anything else with these studies here in this?
No, I think that's a nice place to finish, actually, because we've circled back around, haven't we, to academic trials. So, I mean, kudos to all the investigators, I think, without question. But I still think quite a few things to work out.
Yeah, agreed. All right, cheers.
See ya.
Do you know what I was